All right. Thank you everyone for joining so far. I think it's time for us to start the meeting. So my name is Vasilis Georgopoulos. Generally, people call me Vas. I am the Midlands representative for the MACP, and I have organized this event basically to discuss cervical MRIs. And I have invited my colleague Matt Dixon to go through this topic for me. I know Matt for a couple of years because he's working at the Nottingham University Hospitals and I'm working in the community in pain services. And as part of collaboration between the two services, we have created a spinal multidisciplinary meeting that we hold every month, once per month, to avoid kind of not meaningless, needless referrals and promote basically a more smooth patient pathway. So we kind of meet on a monthly basis to discuss cases and decide together whether some referrals are appropriate or some people should be considered for surgery and so on and so on. And as part of this collaboration, we had Matt give us a talk a few months back about MRIs and how we should interpret them, how we should look at them basically. And it was a very, very enlightening meeting. Very good training for us as a service. And immediately I thought that this is something that Matt needs to do to a wider audience than just the pain services. And that's why I invited him for this meeting. He gladly accepted, which I'm very glad as well. And without having to say anything else, I will let the man go through his work. It's an amazing presentation, so I really hope you will enjoy it. Matt, whenever you're ready.
Perfect. Thanks, Vaz. Can everyone hear me? Just give me a thumbs up, Vaz, if everyone's happy.
Oh yes, and just to want to say to everyone, if you want, just post your questions into the chat box. I will try to streamline them, but at the end we will devote some time for direct questions to Matt if you want. So it's up to you really whether you want to post it or whether you want to ask Matt directly in the end.
Yeah, perfect. Thanks so much, Vaz. So the plan for today, really, like Vaz said, is to talk about the cervical spine. Neck stuff is what I'm most interested in. So it's been kind of tried to streamline this process. I mean, inherently with a group of this sort of size, we're going to have people of multiple different backgrounds, experience levels. So my hope is that we can go through things and give little golden nuggets, hence the title of the presentation, to start getting things moving forward. So my plan, let me just try and share my screen. We'll go through things in order, starting from the kind of basics of MRI, but MRI is just pictures. We need a little bit of kind of mapping that onto clinical scenarios and how we're using MRI scans to think about surgical considerations, really. So let me get my slides up and we'll go from there. Sure. Perfect. Okay. Can everyone see that okay? Yep. Lovely. So golden nuggets, that's the plan. We're going to go through things in order. Please do shout up. I want this to be interactive, or as interactive as possible as it is over Zoom, which obviously isn't as easy as in person. But yeah, please, there'll be lots of times where I throw out a question. What do people think this is? There's no wrong answers. If you're thinking it, someone else probably is as well. So please, the more interactive, the better, because then you'll have to listen to my voice less for the amount of time that we have. We're going to schedule in a couple of little breaks as we go as well. Otherwise, it'll just become a bit monotonous and droning from me. So golden nuggets. Let's see how we get on. A bit of a background from kind of where I'm coming from as well. As Vaz said, I work at NUH, so we are a big hospital. Here it is in the middle, looking great as ever in the British lack of sunshine. We have lots of beds. We serve a big population, and because it's a major trauma centre, we have big tertiary spinal and neurosurgical centres. In Nottingham, a bit different to other places, neurosurgery and spines are kind of split. So that's a bit of an interest. From a spinal side, which is the side that myself and colleagues work in, we have 9 full-time surgical consultants, a consultant physio, Ellie Dunstan, a lot of you might know her, as well as 7 ESP spinal practitioners who are working in that kind of secondary care stroke tertiary care role. from people like yourselves who end up sending people through to us. And so just to give you a scope of how many people that is that we see, you know, spinal wise, attendances of outpatient clinics and as an emergency, you know, we get over 14,000 a year, which is very large. And we see a lot of them. The ED at Queen's Medical Centre is very, very busy. One of the busiest in Europe is my understanding. I think NUH, I think QMC is the 5th biggest university hospital in Europe. So there's lots and lots going on. And it means we really want to streamline this process. So a lot of people end up calling us, NSAU, SD3, some of you might know this, and are asking questions about things related to necks and bits and bobs, not sure what to do with MRI scan findings. So hence the reason to get people involved in this. So I'll be remiss if I didn't say, you know, everyone stands on the shoulders of giants, don't they? So I think two people that have really, really helped me understand more since coming to NUH and working in a spinal surgical service. Mr. Sagai, Magnum Sagai, been a neurosurgical consultant, spine consultant for over 15 years. He's the top boy from a neck perspective for a long time. So I've learned so much from him. I want to thank him and Mr. Dicchino, Dan Dicchino as well. Both these guys are neurosurgeons by background. Why these guys see necks more? Maybe because the neck is closer to the brain, and orthopedic guys like the low backs a bit more, but these guys are definitely, between them, they've got a bowl full of golden nuggets that they've given me, and so hopefully I can pass some of this on. So let's start with sequence basics. If you want to write some of this down or whatever, then please do get your pen and pads ready. We'll be going through things somewhat fast because we haven't got enough time to take it too slow. But please, again, do shout up if you're not sure what I'm on about. So in the spine, we have three major sequences that we tend to use. So if everyone can see my cursor moving here, obviously, we have T1 and T2. This is most similar to kind of what you get in other MSK imaging. But effectively, this is a way to delineate different types of structure, right? So a T2 image is what we see most. We look at those most on spinal MRI scans because they delineate fluid, as in CSF, from nervous tissue. So you can see on this MRI scan here, T2, the nerve roots of the cauda equina are dark, they are black, and then the CSF, the fluid, is nice and bright. So it's a nice way to see the contrast between the two. T1, obviously that's slightly different. The CSF and fluid signal is black on T1. So again, this is useful to delineate between different structures, but T2 is mainly what we're going to be talking about today because it's most useful in our context as physios, advanced practitioners, whatever we are here. Stir sequencing, this is the one little cheeky bit in the mix. This is generally used for an inflammatory sequence. So we use it for things like fractures. If someone's fractured their spine, if it lights up nice and bright on a stir sequence, then we know that this is an acute, inflamed, hot, irritable, fracture. They use stir sequencing on sacroiliac joint MRIs to look for inflammatory sacroiliitis type stuff. So again, it's just a way to look for inflammation, but just so that you're aware of what you're looking at. T1, T2, stir. Let's go next. Is seeming to have stopped work. Let's go next. So, nerve root anatomy 101. This is another really important thing when it comes to the cervical spine in general. So, because of the horizontal anatomy of the cervical nerve roots, no matter where the problem is at a given level or a given place, tends to be, we're talking most about disc or nerve root related bits and bobs. The horizontal nature means that if a problem is in the center, or it's more lateral out to the side, it will hit the same nerve root. So in our example here, at C6-7, no matter where a problem is, it will hit the C7 nerve root. 5-6, it will always hit the C6 nerve root, and so on and so forth. That's different, obviously, than in the lumbar spine because you have a more vertical orientation of the nerve roots, and then as they start to branch out, they become more horizontal. So at L4-5, as per the example here, if you have a paracentral disc, it'll hit L5 most likely, and if you have something that's far out to the side, it'll hit L4. So from a perspective of a cervical MRI, when we're looking at things and when we're trying to establish what it is we are looking at and what nerve roots we are looking at, trying to map that onto patient symptoms, we're always looking at the same nerve root in the cervical spine. cheeky golden nugget for you. So nerve compression sites, another just basic thing from an MRI scan perspective in the spine. We are looking at 4 zones, let's call them. This is obviously this is a lumbar image, a lumbar axial image, and we'll look at the different types of imaging in a sec. But to give you an idea, the different sites of compression are either central, as per the name, and as per the orange area here. This is the thing that we really worry about when it comes to cauda equina syndrome, for instance. If someone has a really large central disc protrusion, they are most likely to hit the sacral nerve roots at the back of the canal. The paramedian, paracentral discs going into the lateral recess here, they are a kind of most typical type for a acute disc herniation. Then you've got the kind of more foraminal, maybe a little bit harder, maybe a little bit older people. And then the extraforaminal or the far lateral disc changes that obviously just hit a different nerve root. So obviously if you've got something coming on at let's say this is L4-5, at the green, if it's the exiting L4 nerve root, that would be affected if it was something going on in the green area. Whereas if it was in the blue area here, it would be most likely hitting L5 as it drops past, if that makes sense. This is a picture of an axial cut of a cervical spine. People tend to tell me that they think that the cervical MRI scans are harder to read. I would agree. It's because of the anatomy and it's because of the sequencing. So again, we'll look at that in a bit more detail as to the different types. But as you can see on this lumbar nerve root scan, you can delineate the nerve roots nicely. They kind of sit there. They're quite happy and on their own. People will say, well, I don't know what the nerve root is. Is it this? Is it this? Is it that? I don't know. So we'll talk to that in a bit more detail. But on this right-hand image here, this is again talking through the different zones. So central as opposed to far lateral. And obviously in the cervical spine, we're most interested in central cord, exiting nerve root. So let's start with the different types of imaging. So in spines, the 2 things that you're going to look at 99% of the time are the sagittal or SAG image, as it will say on the MRI that you're looking at on PACS most likely, or as I would call it, through the ear roll. You're looking through them from the side, okay? When we get one of these up, this is a fairly innocuous looking sagittal image of a cervical region. We're going to kind of try and delineate what the anatomy is, because again, I think I've been guilty of it myself and others in terms of not knowing where they are. So if you don't know where you are on this kind of image, then you end up going with the radiologist report, and you should never trust a radiologist report, really. You need to know a little bit about what's going on yourself. Obviously, the radiologists are medical professionals. That's their whole goal of their practice, but they are variable in quality. So I wouldn't trust them myself. So starting from top to bottom, is the C1 arch anteriorly. I used to think this was the peg. I thought, oh, is that the peg there sitting in there? But imagine you've got a cut through the center of this person. This is a central sagittal image. So effectively, as we know, C1 sits as its ring, C2 then sits through it. So because we've got that slice through the middle, this here, this little circular thing, is the anterior arch of C1, okay? Which therefore means that this bit at the back here, this other circle, is the posterior arch of C1. So that gives you an idea of where that's sort of sitting right below the occiput here and the clivus a little bit further up. This is the C2 vertebral body. So you don't get a full disc in C1-2, rudimentary little change here. So this is the C2 vertebral body here, which therefore means that this is the C3 vertebral body. So the first fully formed disc in the cervical spine is always C2-3. And so therefore, when you're looking at these pictures now, you can hopefully establish, well, I'm looking at C2, I'm looking at C3. So you can start numbering down from there to figure out what levels things are going on at. This is the peg, the dens. So the whole area here, it looks a bit fair more meaty when you look at it on a sagittal scan, but this is what it looks like. This is the dens. So therefore, this is the C2-3 disc. To go a little bit further back or forward, obviously the spinal cord, I'd hope that most of you would know that that's the spinal cord. Posterior CSF, looking at the back. Again, this is important for us looking at whether there is a compressive cord compromise and whether there's still some CSF present at the back, which will become important in a sec. And then at the back here, this black line, this is the ligamentum flavum. So this black line. coming all the way from the back of the occiput here. It's ligamentum flavum. That will become important later. At the front, sitting in through posteriorly to the vertebral column, is the PLL, the posterior longitudinal ligament. So effectively it acts as a nerve net. So when you look at this black thing here, we might see some pictures later, I can't actually remember, as to whether the PLL gets lifted off, and you can see something that's black and thin, or it might be thick, and you go, what's that? That's the PLL. So the posterior longitudinal ligament. Spinous processes at the back here. So that's what you're looking at there, with obviously intraspinous stuff in between, supraspinous on the back here, those sort of things. Right, we've looked at that then. So we've got kind of our through the ear hole sagittal image. We've now got a salami slice axial image. Okay, so this is a salami slice image of C4-5 on a particular MRI scan. We will look a little bit as to what we're doing, but we've got anterior, so chin here, posterior, skin at the back, and depending on how cuddly your person you're looking at their scan is, how much subcutaneous fat stroke muscle is in there between this and the spine. An important note on salami slice pictures, axial cuts, for anyone who doesn't know, is that we are looking at, from foot up. So effectively we have the left-hand side here and the right-hand side here. So that's where some, if you're new to looking at scans, that will be something that you get wrong. You'll say, oh, this is something on the right-hand side, but in fact it's on the left because we're looking foot up. Okay. Normally on your PACS, it should probably have a little L delineating that it's left and a right delineating that it's right, but it might not do. This is the disc, so centrally here. And then this is the facet joint. So this is the left-sided facet joint, and you can see this little bit of white in there. That's a bit of fluid, so potentially that might be symptomatic or not, who knows, but that's the facet joint there. Spinous process at the back. It's obviously not quite as pokey in the cervical spine, not quite as meaty. So obviously in the cervical spine, you've got two parts of the nerve root that leave off the cord. This area that we have here is the dorsal nerve root, and the ventral nerve root sitting a bit further in front. So these little wispy lines here are the starts of the nerve root, where it forms and becomes a fully formed spinal nerve more laterally. So if you remember all your anatomy and physiology from physio school, that might be of use. You might remember some of this stuff and what the different types of nerves do. We'll talk about that later. And then you've got your egg yolk. So spinal cord sitting in the middle. I always like to say with patients, this is our salami slice picture. We've got our fried egg in the middle. The egg yolk is the cord. The egg white is the fluid. CSF. Simple as that. The last thing, just not to try and bore you on the technicalities, but again, this is hopefully useful so you can orientate yourself. If you have a person in front of you and you have PACS and you're looking at their scans and trying to figure out what's going on with them, or just to help them understand and try and de-escalate or whatever it is you're doing, cervical sequences are a little bit different and a little bit trickier. So let's go through it. So you've got your... Sorry. So this is our sagittal sequence. This is an axial sequence, but so is this. And you'll often see these two and you'll go, well, what's the difference between the two of them? This is very boring. It's all radiological and about physics and bits and bobs, and that doesn't interest me whatsoever, but it is useful in terms of knowing what you're looking at. So this type of image here is a multi-echo sequence, a T2 underscore multi-echo 2D, obviously, because it's not a 3D image, TRA, which on the right-hand side here, we've got a turbo spin echo, T2 TSE underscore TRA. Effectively, TRA is transverse. So effectively, we're delineating different structures with these different ways of them spinning the magnets. That's as far as I'm going to go from the physics perspective. That's the reason why I did physio, not radiology. So T2 multi-echo, this type of image here is really good at stopping CSF flow void artifacts. So on this side, for instance, if you can see where my cursor is, you're picking up at the back here all kinds of flow of the CSF as it moves through the spinal canal. This stops it, so you can more easily delineate the nervous tissue. You can also, if you squint very slightly, some images are better, you can see the actual intracord architecture, so you can see the different tracts, which is pretty amazing, and we'll probably have an image of that later. You can also obviously then pick off the ventral and the dorsal nerve roots a little bit easier, as opposed to this, which kind of just, I don't know, it's Mickey Mouse, isn't it? You can't really see a whole lot. There's this black stuff here, not very useful. However, these are quicker to get. So radiologists like them. They're quick, they're fast, they get people through an MRI scanner well, and they also delineate soft tissues nicely. So on this side, everything's kind of light gray, all looks the same. Whereas on this side, we've got lots of black and bits of fat and white and everything, so we can see things in a bit more detail from a soft tissue point of view, which may be useful in a trauma context, I don't know, and soft tissue tumors and all the rest of it. Again, we're starting off all this sort of bits and bobs with the basics so that we can start to then figure out when we start looking at images in a second, what it is that we're looking at and how do we describe it. So hopefully part of the, at the end of this, if you can pick up some of the golden nuggets is, well, I'm looking at an image, how do I describe it? What level is it? What kind of pathology is it? Where is it? What does it do? All of these things, so you can start almost reporting your scan findings like a radiologist does, which is just following this very structured approach. So obviously you're all physios, you probably should know the difference in these different pathology types, but MRI scan wise, let's have a look at the difference. So this obviously is a sagittal and an axial image of L4-5 in a lumbar spine. I've used a lumbar spine for this because it's a little bit easier to see rather than cervical, and we'll start that a bit more detail. This is a bulge. It's diffuse, it's broad base, it's not really doing a whole lot of anything. It's not that interesting to the interventionalist, surgeon, whatever. This is a protrusion. So by definition, a protrusion is like a pyramid. Effectively, it's smaller at its base. Smaller at its apex than it is at its base. It's pyramid sort of shape, right? This thing obviously is a bit more interesting. This is doing something in the canal, so we could probably start to delineate what that is. It's a L5S1 because it's looking between the two, left-sided disc protrusion compressing the descending S1 nerve root, definitely. So we can start to delineate what we're looking at. This little black line here, that's the PLL we were talking about earlier. So that's been lifted off the back. So when you're looking at the lines, that's what you're looking at, PLL. So bulging protrusions. This will become more important later when we look at what we're doing for certain surgeries. So here on the left-hand side then now we have something that looks different, right? We have an extrusion material. So on MRI scans, annular material, the annulus pulposus, annulus fibrosus of the disc is dark, it's black, it's thick, whereas the nucleus pulposus is nice and bright and varying shades of lighter gray on an MRI scan. So as soon as you start to see something that's brighter like this, you know it's nuclear material, nucleus material, which means it's softer, which means it has generally a better natural history in terms of its resolution. So you can see that quite nicely, the difference in colors between the two. What delineates that from a sequestration is that effectively sequestration is something that's kind of completely left. It's no longer congruent. It's no longer part of the original disc. It has no way of kind of staying intact with the disc. It's just kind of floating in there. So these things are super big. They tend to be super painful. And depending on where they are, we either really want to get them out or we let them do their thing and improve because they're so soft and so easy to chew up. So let's go through the simple bits of cervical canal stenosis, central cervical stenosis, the main motorway where the cord runs through. If you look in the radiology paperwork and textbooks on this, there are 1,000 different ways of delineating different grades of stenosis, what it is, where it is, what layers of the CSF and all this it's effacing and touching and impinging. And you'll see all this on your MRI reports. And if you're like me, I just look at the pictures because it'll tell me what really matters. From this perspective then, so we have a normal MRI scan sitting in through here. The cord has CSF anteriorly, that's the white, and CSF posteriorly. Yeah, the cord is fine. Mild stenosis. I like this way of thinking about it. It's just more simple than thinking about how much percentage of the canal is it occupying, etc. Partial effacement. This is the stuff that, again, radiologists will report on, but we're really not that interested on from a surgical perspective. If there's mild partial CSF effacement, either from the front, from the back, or from both, but it's not really compressing the cord, not really of that much concern. Moderate, it's effacing the CSF completely and it's starting to move the cord somewhere. If you, in your mind's eye, think about, well, this cord is dropping from top to bottom, if it's been pushed out of the way, like in this one here, so something is happening at the front there, something is happening at the front and the back here, the cord has been pushed and moved around. This is when we start to get a little bit more interested. And obviously when someone looks like this and they've got massive cord compression with looking a bit of signal change in there, this is obviously the thing that the spinal surgeon or the surgical services are interested in, very much so, potentially. But obviously, as we go on to that, this person may not necessarily be symptomatic. So let's see. Let's go. So we have two pictures here. Does anyone want to give me a guess as to what we're looking at? Does anyone want to shout out? Be brave. Obviously, the title of the slide is useful in saying that there's some signal change stroke myelomalacia, if anyone knows what that is.
So, sorry, it's just Kamal speaking.
Hi, Kamal.
Both of the images have signal change, as you can see, but one of them has
Yep.
clear cord compression still.
Yes. Yeah, sure. So there are two images showing myelomalacia cord signal change. But again, this is where it's important to be able to look for yourself at these images rather than to rely on a radiologist's words, because they may well say cord signal change, high signal intensity myelomalacia, and you might in your head think, well, that's the same thing, but it isn't necessarily, right? As Kamal said, there's two different things here. So one thing to bear in mind, if you look at something which is acute, and with regards to anything in the spinal cord, if it looks hazy and looks like you can't really draw a very good delineated line around it, it probably means it's fairly fresh and fairly new. It's an inflammatory nature to the cord being pressed on, abutted. Something's happening to the cord. It's a acute response of the cord to losing its oxygen supply secondary to compression. Whereas something that's been there for quite some time generally starts to become more delineated. So you can draw a circle around it. It's got a narrow zone of transition. It's easy to see what you're looking at. This thing's a bit hazy, nice, soft disc here. Obviously still some PLL behind it, but we've got a C3, 4, 5, 6, 7. So now you can start to do your numbering. This is a C6, 7 central disc compressing the cord, causing signal change, right? Whereas this is a C5, 6 disc, 3, 4, 5, 6, which is somewhat, this is kind of that grade 2 moderate, isn't it? It's not horrendous, but it does have some signal change there, potentially insinuating that it was compressed and then now it's got a little bit better, or that it's just been on there for some time and the cord's kind of remodeled and done what it can. Right. So at that point there, let's have a little bit of a break and then we'll go back to talking through the triangle. I'm going to give you all 5 minutes. So with my timer, I'll start it now, and in 5 minutes we'll crack on, because at this point now we kind of know where we're at in terms of looking at things. Then let's start to kind of bang through things from a perspective of the all important triangle. So go and have a drink or whatever you need to do, and we'll see you back in 5 minutes. Okay, right. I've got the chat up, so I'm just going to go through a couple of the questions. We can talk through. So, chord signal changes. Yeah, Spencer's right. So, Priya, your question was about inflammatory has a better prognosis compared to a solid, distinct outline. No, not necessarily. So let's just see if I can answer the question correctly. Inflammatory just means that it's a new process, a hotter process. So from a perspective of a surgeon or a perspective of how we manage these things, if something is new, acute, and hot, we really want to get that pressure off the cord. So if you've got someone who's 30 odd, we'll see some cases later where they get a new large, acute, big disc prolapse, and the cord looks like that, inflammatory. I'll go back to my slide. Something like this. You really want to think about, well, are we going to operate on this thing to give the cord its best chance of recovery? Because that's an acute response. If the pressure is left on the cord for long enough, effectively, the oxygen supply is lost to the cord, and then the cord starts to die. So depending on what the blood spinal cord barrier and perfusion is like, if it's left to become like this, and it's that kind of solid, distinct outline, it's more chronic, it won't improve with surgery, really. It's much less likely to. There are other little tricks you can do for that, which we won't go into today. It's just a bit too much. But when something has been left to become chronic, the likelihood of you getting an improvement within the cord's perfusion again is low, because the brain tissue is, or the cord tissue is dead, in the same sense as in a stroke, whereas if you can get to something whilst it's acute and hot and inflamed in this kind of image, potentially you are then able to take the pressure away from it, restore the oxygen supply to the cord, and give it a better chance of recovery, or at least stopping it from getting worse, if that makes sense. But any more questions, please do chuck them in, and we'll chat them through at the end.
Yeah, I think we can carry on.
Sure, perfect. Right, okay. So let's carry on. The triangle. This is an important, useful way of thinking about the spine when it comes to structural perspectives. So for us as physios, we're all trained in symptoms, aren't we, really? We have this weird thing where we do a bit of the biomedical model in terms of looking at what structure is like, but then we do this thing of looking at what symptoms are like and caring about that and trying to help people with symptoms, because we know that the two can be linked, but they are also sometimes not. The triangle, so this is very much, if you are going into the biomedical realm now, we're going to leave the biopsychosocial framework and all the rest of the other stuff that we do behind. We're looking very much as a through our structural lens, structural paradigm, to try and figure out, well, what we're doing with things and why are we doing what we're doing, or why is there a need for someone to start cutting into someone's neck. So the 3 points of the triangle, I find it a useful clinical reasoning model when I'm looking at something or trying to figure out with someone what's going on. Are neurology. The primary goal of most spinal surgery really is to protect or do something with regards to neurology, the big stuff anyway, the kind of more emergency stuff. Pain perspective, obviously that's important. And then stability of the spine, because obviously the spine is a very complex structure in its essence. And so therefore, if the stability is compromised, then potentially this could almost like have a feedback loop towards pain, a feedback loop towards neurology, and then vice versa. Neurology can, painful and neurological conditions. But it's important to try and figure out what it is we're treating along this kind of paradigm of the triangle. We'll start with neurology. So DCM, myelopathy. This is the main thing with regards to the neck and neurology, isn't it? The cord. This is what we see most of all. So DCM is most commonly caused by degenerative stenosis in the canal. If it's something from the front, i.e. disc, something from the back, i.e. ligamentum flavum, or some hardening of ligament, PLL, we'll talk about that in a bit. This is a standard looking mid-50s person with DCM who had an operation. They have some changes coming from the front here, anteriorly from disc, some from the back, some circumferential compression of the cord. It doesn't look crazy. There's not a lot of signal change. We can't really see much there, but certainly there's nowhere else for the cord to go. And so as you're looking in there, you can't really see any CSF on our axial image. This is someone with who is symptomatic of DCM secondary to cervical stenosis. Or, as we looked at on the other one, we've got an acute disc prolapse. So this is the same picture again with the axial cut, an acute and softer looking pathology than something that's been building up over time. The important part for us to get right about our diagnostic process is that DCM is a clinical diagnosis. It's not something based on imaging. The imaging is there to confirm. So it's important that we get that right in our heads in terms of what we're doing when we're seeing someone and thinking, okay, do they have DCM? Unfortunately, at present, as a working group, Recode DCM are trying to do something about this, but there's no established diagnostic criteria to say for sure 100% someone's got DCM, which is quite annoying and frustrating for us as clinicians because we like things to be black and white, but that's not the case. The gold standard is MRI, if we can get one, for no other reason that people can't have an MRI. But from the perspective of an MRI scan, there's no clarity on whether having some signal change or some myelomalacia or how significantly compressed the cord is. There's no correlation between that and someone's symptom burden. So, you're looking at pictures to try and figure out what you do about someone, but you can have terrible pictures and be okay, or can have pretty mediocre pictures and be really suffering. So the MRI scan is a confirmatory part of this process. You have a thorough history of symptoms. You do a neurological examination to figure out what's going on and differential diagnoses, of which there are plenty. And then you get an MRI scan to refute that, or to give radiological confirmation that the cord is compressed, thinking about, okay, do they need to see a spinal surgeon to get that taken off? So the real big take-home point for me then would be that cervical stenosis is not myelopathy. It's just a radiological finding. But myelopathy being the clinical diagnosis with which cervical stenosis influences its development. So obviously, if you have no cervical stenosis, you could have all the symptoms you want, but you've not got DCM, right? The cord isn't compressed by nature. Another thing, cord signal change is myelomalacia. Cord signal change is not DCM. Again, you'll see the radiologists put in their reports there is evidence of myelopathy on the MRI scan. That's not true. There is evidence of myelomalacia or cord signal change, which could be indicative that this person has myelopathy clinically. The important part to understand is that there's many studies now. This is a study nearly 10 years old from Japan with over 1,000, I think 1,200 asymptomatic people, and 2.3%, so a fairly significant number of the population, walk around with some signal change on their MRI scans, but they were all asymptomatic. So, what does this really mean? Especially when our Ianurian colleagues have found that people who are confirmed definitely myelopathic, they have the symptoms, they have the signs, they have cord compression, and they undergo surgery, they don't have cord signal change in a good number. So it's not the be all and end all. That's just part of the process that helps us to understand with some nuances, how they're going to do, which is a cheeky little golden nugget for you. So what do we think this is? Is anyone happy to shout out? We've now got two pictures. So we've got a sagittal MRI scan of the neck, and then we've got, obviously, at this level, which I'd want to know, which level is it and what are we looking at? What is the problem here? No wrong answers.
Hi, it's Kath Morris.
Hi there.
I think it's 5, 6 acute. On the left-hand side, we've got an acute disc causing the myelomalacia changes there.
Yeah, nice.
And then on the right, is this the same person? You can see
yes.
the
So
large disc then
all the studies will be the same
compromising
people.
centrally into the canal.
Yeah, perfect. Bang on. Thank you so much. Thank you, Catherine. So we have a C5-6 disc. It's acute. It's a little bit funny, isn't it, on the sagittal image, as to you can't see the disc material so much, but that's just because it's quite so soft. You can see on this side that it's a bit of a brighter color in there. This is an acute disc in a young person. This person was in their late 20s, which is quite worrying, really. Frankly, myelopathic. this is hazy cord signal change just happened. And so for us, this is like a surgeon's, this has to be done right now. So this is his intraoperative images coming in through here, through the front, intubated with all the surgical kit and paraphernalia. And then this is him after his surgery with his nice earring in there, an ACDF from the front. So an anterior cervical discectomy or decompression and fusion. So this is an emergency case, someone who's young, who has an acute disc, very frankly myelopathic, needs something doing about it. Okay. What's this? Anyone else have a thought?
Yeah, I think hi. Hi Matt.
Hi
This is C34 disc.
Yeah.
It's fairly chronic. There is signal changes, and there's severe degenerative change across the whole cervical spine, but the most significant one is C4, C34.
C34, perfect. Yeah, exactly. Perfect. So absolutely right. We have a disc here compressing the cord. As you've said, the difference between the two images is quite easy to see, isn't it? We have one thing that is nice and new and hazy, and this one, which is, again, well delineated. This is in an older person, someone in their early 70s. And so we can draw a nice line around this. This has probably been kicking around for a while. Now, what's interesting is that obviously in early 70 people, we don't tend to really see acute soft discs like this. So one of the things that we were thinking for this one was, is this a calcified disc which has just thickened up and become hard? And so a CT scan revealed that no, it's not. It's soft. This is soft disc material. There's no bony changes like you can see here. So at C34, where the big disc is, there's nothing really there on CT. Below that level, it started to calcify a bit here. The important part about this is the kind of dish, or the anterior osteophyte bridging at the front. So basically, they've fused their own spine by growing this stuff, and then this one's wobbled around more and spat a bit of disc material out. So interesting, something you don't necessarily see every day. Okay, what's this? Let's try and describe it.
So this looks like there's C3, C4, and C4, C5 compression from, looks like PLL or perhaps OPLL, but there's also circumferential compression from the back at C3, C4, and potentially C4, C5 as well. And there's some cord signal change at C3, C4.
Perfect. Yeah, I would agree. So we can see the difference between the imaging here. Compare the one before. So if I go back, clearly that was anterior pathology. There's still a little bit of posterior CSF kind of kicking around at the back here. This is very different, isn't it? We've got something more so, if you kind of squint your eyes and look at that, I would say it's probably been pinched a little bit more from the back. So there's a little bit of hazy signal change at the level of C34. Thanks, Kamal. And most of this kind of pressure here is coming from the posterior structures. So again, that's why we kind of pointed out at the start, this is the posterior longitudinal ligament that's thickened up and it's starting to compress the cord. On MRI scans, that then looks kind of that dark gray at the back there. So you could be forgiven for thinking, is that just CSF and it looks a bit funny? But no, that's what ligament looks like on MRI, which is compressing the cord from the back. So, yep, good. So from this perspective, just one little golden nugget for you whilst we're there. Posterior longitudinal ligament changes and compression of the spinal cord from the back inherently is going to affect the posterior column and the posterior tracts of the spinal column. And those are the ones that we miss from a myelopathy perspective. It's a known kind of subtype of myelopathy, which doesn't occur all that often, but people who have no hand and arm symptoms, they're just leg. So they get like this giraffe and they're all over the place and they're wobbly on their legs. And they come in and either, because it's a preganglionic lesion and it's not a nerve root compromise, they don't necessarily have much neck pain, maybe none at all, and they're wobbly on their legs, so they end up going to see a neurologist, which takes ages, and get an MRI scan of the brain and there's nothing on there, or maybe because their legs are getting really bad and all weak and etc. when they walk, maybe someone thinks it's a lumbar spine, so they scan their lumbar spine and no doubt they find some changes there, and then they get sent in to us at spines, and in the end it ends up just being the neck. So again, something they didn't teach me in physio school, or I never heard of, or wasn't listening, or wasn't there, is about tandem stenosis. So compression at the top, compression at the bottom, hose pipe analogy, two kinks, So this is one thing to look out for. Thorough neurological examination. If the posterior columns have been affected in the cord, you may well just see leg symptoms. Cheeky golden nugget. Okay, what's this one then? Someone try and describe it for us.
So I think again it's a multiple level lesion over C2 3 4 4 5, compressing the spine from the front and the back on C2 C2 3 and 5 6 and also 6 6 7 down there, isn't it?
Sure, yeah. So the only thing I think you're completely right, apart from your leveling. So C23 is this one.
Yeah.
There's still posterior CSF. So C34 is the first level of significant compression, and then we have basically from there down. So 3 4 4 5 looks like it's previously had something going on with it. There's a bit of signal change in there. They might have had a disc which then improved, or it might just be knocking around, or it might just be tracking down the signal change. 5 6 6 7. So whole thing, all circumferential. This person had a PCDF. Circumferential. So one last point on this, which is useful from a radiological standpoint and would make you maybe change your management or your thoughts on people. So this is a concept that's come into being over the last few years. Ari Nuri and colleagues, good paper to have a little look at. But the idea of having a cord canal mismatch. So effectively, you have a situation where someone's cord is too fat and it sits in too much of it's too thick and it sits in too much of the canal, or the canal is too small. And so therefore there's a mismatch between the two. It's occupying too much of the spinal canal. And then so obviously we can see the difference in the imaging. This person has plenty of space in there. Although they can have some compression on it, this person is at far greater risk of developing something, aren't they? I mean, even if they only get small changes, the cord has nowhere to go. So this is a good just thing to have in the back of your mind. If you're looking at MRI scans and you look at something and go, where's the CSF? There isn't much. This person has a cord canal mismatch, and potentially we might be a bit more worried about them in terms of their especially long term, in terms of what we do. So, sorry, I'll go back. So, the one last thing to go through from a cord perspective and the main central canal would be, okay, when do we go from the front versus when do we go from the back with these kind of patients and people who've got problems, with the main motorway? So we go from the front generally if someone has compression from the front. So there's no point really if you've got a one level disc that's compressing the cord from the front, then going from the back and doing a posterior surgery. We tend to address where the compression is coming from, or at least we should if we're technically able from a surgical perspective. Obviously, I'm not a surgeon, but that's the kind of way we go. Less levels tends to be better for anterior surgery. The more levels you do, the more chance of injuring the nervous tissue, etc., that sit in the gullet, and all swallowing difficulties and speech difficulties, etc. And it's just a much more significant thing to do. We tend to do it in younger patients as well because it preserves their range of motion. They get less neck pain. Posterior stuff we tend to do for more posterior compression, circumferential, more levels, older people, and then maybe if they have a cord canal mismatch, just to give more space for the cord. So that's just again a little bit of thoughts when it comes to surgical approach. Right, let's get moving then. So from a pain perspective, let's shift the triangle. Let's look at the exiting junctions. This is something that people tend to tell me that they really struggle with in terms of knowing what they're looking at with an axial view. Where are the nerve roots? Where's the nerve compression? I can't really see it. What's going on? So by definition, obviously the nerve roots are exiting out to the side. And so a mild change, obviously they've got loads and loads of space in normal. Mild change is less than 50%. It's just kind of slight narrowing of that exiting tunnel that we have here between the disc and the kind of the outer area of the lateral recess and the facet joint there. Less than 50% is mild. More than 50% at the level of actually where the nerve comes out from. It's easy to see on these kind of images that we looked at earlier, wasn't it? When we looked at the multi-echo versus the spin one, which looks like this. These are easy to see the exiting nerve roots. It's there. So that's mild. The nerve root has been more significantly, irritated, or the foramen is narrower. And obviously on this side, you can't see any space for the nerve to leave out of that. Now, an important point about all this, obviously, and especially when it comes to surgical stuff, is that pretty much everyone has some foraminal stenosis in their neck. By the time they're 20s odd, 30 odd, there's going to be some changes. The real question is it worth us cutting someone's neck open and risking them all the potential problems that go along with that, notwithstanding cord injury and paralysis, long-term neck pain, these kind of bits and bobs, adjacent segment change, we'll talk about in a sec. There's many risks of doing a neck surgery, and most people tend to get that. But just because someone has some foraminal stenosis and it's been reported by a radiologist and they have a little bit of symptoms in their arm, etc., it doesn't mean we necessarily need a surgical discussion. The question is when and why and what are we doing? So the big thing to say is that from a cervical radicular perspective, certainly within our unit, we care about someone having nasty arm pain. If they have horrendous arm pain, which we know is coming from a nerve root in the neck, we're interested in that. Plus stroke minus radiculopathy. A bit of numbness, bit of weakness, it really isn't the way to go to try and start to cut people's necks open. So ACDF, this is how we do it. So this is an example for you. So an ACDF for pain, this guy has got 2 level changes. So we can now see, based on our MRI scan understanding, the main motorway looks pretty good, but the exiting junctions, they ain't got a whole lot of space. A little bit of change here in the exiting junction, the main motorway. Cord's been posteriorly displaced, but it's not terrible. It's not crazy like those are the pictures we were looking at. There is some moderate stenosis in the canal, but the exiting junctions are worse. This guy had left-sided arm pain, and so we can see C5-6. There ain't much space there. That's severe, as well as 6-7 on this side. Of course, that's moderate to severe change as well. So you're not just going to do one, because then it's just going to make the other one worse, and we don't really know which one the arm pain is coming from. So we end up in someone like this having to do a 2-level surgery. So this is a 2-level ACDF for someone with unilateral radicular arm pain. It's quite a lot to go through, isn't it? But then we get problems with these, don't we? So when we fuse these areas by doing an ACDF to get to the nerve roots from the front, but then potentially we end up getting a next one up phenomenon, the adjacent segment changes. So this is an example of someone middle-aged. This is their scan in 2021. C4-5 looks pretty good. 5-6 looks pretty poor. There's got some subtle signal changes within the cord. The exiting nerve roots haven't got much space at all. You can see how flat that looks compared to this. So she had myelor radiculopathy, i.e. some cord symptoms and some cord problems and some radicular symptoms. So myelor radiculopath, 2021, has an ACDF at that level. And then 2023, this is the MRI scan now. So we stop the problem in one place, but then we just move it somewhere else. So again, this is what we kind of set people up for once we start doing things. This is quite quick, but there's about a 3% chance per year in the first 10 years that someone develops adjacent segment change. So it's something to consider. This is C4-5, and that's going to have to be done now. You can see the problem here. It's just going to go to a certain point. For younger ones, and for single level stuff, maybe multi-level, but more likely single, ACDRs, disc replacements, arthroplasty as they call them, or they used to call them, is another option. So this is less of a fusion, supposedly. If you have something here that you want to get from the front, you can put one of these in, a disc replacement. But again, the problem is that your body can fuse this, even though it thinks it still can move. Sometimes it just fuses anyway. The idea being that you preserve motion and then stop the adjacent segment problems. So that's one way that some people attack these things. They tend to be quite good for disc material. They're not quite so good for kind of harder osteophyte, older person, difficult to get in there. So younger people generally. And a foraminotomy is the other way to go, so from the back. Now, we don't tend to do that many of them, or at least the guys that I work with don't tend to do that many of them. The reason being that you can preserve the disc from the front and not have to mess around with going through the front and fusing, etc. You can come through the back through this way and start to decompress the nerve from the back. So this is a case of this young lad. We can see there at C6-7 on the right-hand side, he's got a foraminal disc, which is pretty hard. It's black on the sagittal image there. You can kind of see where my cursor is. This is what people can't really see on MRI scans of the cervical spine. This one's quite easy. That is the C8 nerve root at C7-T1 with the white in the CSF around it. And obviously in this area here, there ain't no space. So the C7 nerve root has been compressed there. And one way to do that might be to do a foraminotomy. So cut from the back and give the nerve more space by taking some of this bone away here. The problem is that when you do that, you can violate the facet joint. So you can make something unstable unilaterally on that side. You can then cause people more neck pain afterwards. So again, it's these problems, isn't it? We don't tend to do as many of them. One thing to bear in mind, I'll just leave you this little cheeky bit of again another nugget, but something to ponder. So like with back pain, we say we don't operate for neck pain, we operate for arm related symptoms and arm pain, and the same for back, isn't it? We operate for leg pain or nerve compression. But this is a really interesting study, actually, published in Spine a couple of years ago now. An American group. They had nearly 5,000 people undergoing surgery for radiculopathy or arm-related symptoms, and these were their outcomes. So people's neck pain and arm pain preoperatively, both high and both improved. So again, there's nuance to these things, and we're not just sending people for neck surgeries if their neck hurts. It's not the way forward. But it's just a pause for thought that sometimes if someone does have significant neck pain, as well as some nerve compression, as well as some arm symptoms, etc., it might not preclude them from getting some improvement with interventional approaches. But a pause for thought. Another thing that we really commonly see, so again, another little cheeky nugget for you, is the idea of double crushes. Again, I didn't really learn this at physio school, or wasn't really as aware of it until kind of looking at some of Anina Schmidt's work and seeing much more of this running as a cervical specialist clinic. The idea of having problems at the nerve root level as well as at the periphery and them compounding each other. So it's really useful if people who work in MSK services make use of nerve conduction studies, stroke EMG. Look if EMG evidence of radiculopathy, look if peripheral evidence by a nerve conduction study of compression, so things like carpal tunnel, obviously. And if there is a double crush, if there is problem going on at both, we always treat the periphery first. So this study, again, from Anina Schmidt over 10 years ago now, people who have successful improvement following carpal tunnel release, these are their symptoms before surgery. So, loads of people get arm symptoms, even some people get neck pain, which improves with carpal tunnel. And I would suspect the mechanism of that is probably a double crush mechanism. It's much easier to do a day case, small procedure on the wrist than to cut someone's neck open and fuse their neck, most likely. So this is just another little tidbit for you guys who are responsible for referring on to secondary care. So again, think of your hose pipe type analogy. Kinks at two places. We want to unkink one and see what happens first. Another golden nugget. Injections, another point for you to look at. So this is a C6-7 disc and change. And so the question here is, what are we going to do? Are we going to do a diagnostic injection to try and figure out whether this person would benefit from surgery? And you can do a diagnostic injection. Here's one been done. This is nice at C6-7. Problem with these is that someone, again, I didn't understand this until I got into surgery services, so it may be useful for some of you. The person has to be okay enough to lie on their back and have someone put a needle through their neck from the front whilst they're awake and not move, not do anything, because their vertebral artery sits right next to the nerve root. So these have to be people who are able to do that, and there is obviously some risk and some difficulty with doing that. Not many people can do cervical nerve root blocks in our region. Generally tends to be pain consultants. The surgeons don't really do them at all. They are difficult, so they're not really an easy tool to get an injection like this, like a lumbar nerve root block is. So just a case in point. So this is a patient of mine, middle-aged person with left-sided unilateral C6 nerve pain. You can see that there. This is fairly severe foraminal stenosis on the left-hand side. And so my question was, can we do a nerve root block for her? Let's see what's going on. That could be useful diagnostically. She was a bit shouldery, a bit, let's see what's going on. But we couldn't because of this. So that's the vertebral artery sitting right in the foramen there. There's not enough space to be able to advance the needle in. So again, another thing for you to think about before sending on to surgical services. This is why it's useful to have discussions with, your colleagues who work in them to try and figure out whether it's worth doing or not. Another one then. So what is this? What do people think this is? Someone shout up. Okay. So
extruded disc.
yeah, thanks, Catherine. Yeah, so yeah, this is a disc extrusion, right? So we can see the difference now that we've looked at the scans and kind of what we're looking at. We're looking at a softer disc extrusion. It's nice and light on MRI. It's dark, obviously the annular material dark black. This is nice and bright, isn't it? So a disc extrusion, nice. And so the question is, do we do a nerve root block for her? Is it reasonable to do? She's in agony with arm pain. Do we do one? Well, actually, by the time that she got to having it done, she'd got much better because it's a nice disc extrusion. So we don't have any pictures because she did great. So again, these guys are really good. They can manage really well with no interventional treatment. And so this one, what's this? What do people think that is? Again, just quickly shout out what, based on our classification system, what is it?
This bulge?
Bulge?
Yeah.
Okay.
Protrusion, sorry. Protrusion.
Yeah. So it's a bit protrusion. Yeah, no, not at all. So a bit of a protrusion, but more so I'd say there's a protruding element. This is somewhat complex. A protruding element, but then there's a bit of disc extrusion to it as well. It's still encased in annular material, at least here. Potentially at the bottom there's a little bit of extruded component, but I would agree this is a disc which is less soft than the last one we looked at. There's her having a nerve root block. So question is, was it useful? No, it wasn't. We ended up having to do an ACDF for her. So again, when you're thinking about surgical consideration for these guys, you've got to be really, really sure you're going to do the right thing for someone when you're going through the front of their neck to operate on them. Hence why we do use things like nerve root blocks not very regularly, but just to try and figure out how much improvement they might well get with surgery as a diagnostic. Okay. What do you want to do, Vaz? Because the last lot is more kind of cases. What do people think? These ones are a bit more outlandish, and people can shout out things, and then we'll have time for questions. So what do people want to do? Do you want to run straight in? Do you want to have 5 minutes and then we go for until the end? Or
I think you can carry through just a little bit more slower, maybe if somebody wants to chip in anything.
Sure, yeah, please
Okay.
do shout out, guys. Otherwise, you'll just be listening to my voice.
Feel free to unmute yourself and just ask your questions. No problem at all.
Sure, yeah, and chuck them on the chat for the end as well if you want to. Yeah, sure. Okay, so the last point in our triangle then is our stability factor, right? So one we have here, I mean, what's going on there? What do people think that is? Obviously, I've got a title to the slide, so there's a subsidence somewhere. Something is not as it should be. What do people think that is? Or how would they describe it, maybe?
Like a spondylolisthesis.
Yes, of
Yeah.
C5 and C4.
Yeah, sure. So it's a bit of a complex one, actually. It's not like the most run-of-the-mill spondylolisthesis, but you're completely right. It's a spondylolisthesis. This is the kind of spondylolisthesis that you probably do want to do something about, right? So you're right. It's between C4 and C5, and it's kind of hard to categorize. Really, we tend to talk about it as to what's the top one doing on the bottom one, but this one is kind of like C4 is anterior to C5, but then C5 is posterior to C6. So this is a complex listhesis and deformity that's come along. Obviously, the cord is compressed and it's got some signal change in it. And when you flex and extend this person, effectively C4 is just rocking around on this X-ray. You can kind of see that this, this vertebral body is kind of dropping off the end when this person flexes their neck, which is probably not very useful. One of the reasons why it might have happened, as a little clue, is anteriorly at the front here where you can see my cursor, they've kind of beaked and made some osteophytes at the front again. So this person has stabilized themselves and fused themselves lower down. And now this segment has failed and become mobile. This is true dynamic change, right? We don't like talking about spines being unstable as physios. It gives us chills, doesn't it? But this is a unstable spine, and therefore it needs surgery. So this is them doing a corpectomy here. So at that level, that's what it looks like, effectively getting rid of the whole vertebral body and putting a cage in there. So yeah, this is pretty extensive stuff. Question is, this is the same person. What's that? So this is after surgery, day one. What's that? What's going on there?
Is it bleeding?
So not bleeding, but good point. Yeah. Anyone else got any thoughts? I mean, I wouldn't expect people to know necessarily.
Inflammation.
Say again?
A swelling or inflammatory is going on?
Yes.
Some
Yes.
cord edema.
Yes, perfect. Well done.
Yeah.
Bang on, yeah. So this person has had a corpectomy, a big corpectomy. The problem with that, of course, is that then now suddenly the cord has been compressed and now suddenly there's oxygen supply that's rushed back to it. So what they've developed is a cord injury, a reperfusion injury. The oxygen supply has rushed back and it's injured the cord. And so you've now got this edema in there. That's perfect. You've got it exactly right. The cord is swollen and the cord is looking a different color. This is acute inflammatory change in the cord, secondary to surgery. This person needs steroids to try and get rid of that and try and help that cord. And then you can see at 2 months how, again, nicely you can see there how it's become a bit more circumferential, and you can kind of narrow zone of transition. You can understand how the cord has remodeled. Obviously, sometimes MRI scans are difficult to look at when someone's had previous surgery and they've got this weird metallic artifact coming on, especially in corpectomies. But you know, this, when you see stuff that looks like this, they've had previous surgery, of course. White cord syndrome. Okay. This one, I'm not going to ask you to kind of say it. It's not that sexy, but again, just to think about from a perspective of stability of the neck. So this person had severe neck and bilateral arm pain. I've not put the axials on there, but this person doesn't have a normal lordotic neck. It's not sitting like it should do. This is kind of, so 4 is kind of anterior to 5, which is kind of, then, you know, 6, 7 has got a slight listhesis to it as well. This person is someone that wasn't easy to sort out surgically. So this person ended up having a 4-level ACDF. And you can imagine what a significant undertaking that is. This person has to then be in a collar for 3 months, plus, you know, real problems with speech, swallowing afterwards because of what you have to do. You know, this is significant. So there's nothing, this person has to be in horrendous neck and arm symptoms to consider doing something like this, you know. But that's a, you know, a degenerative neck that's changed its stability. What is this? Anyone hazard a guess?
Syrinx?
No, but good question.
No.
Yeah, good point. Any thoughts?
Fracture?
I mean, yeah, you could certainly think it might be a fracture. Yeah. Any other thoughts? Or I mean, yeah, it's hard to know, isn't it? That looks really odd.
Looks like a cervical deformity where C4 and C5 is kind of fused into a weird shape.
Yes, into some kind of weird hybrid vertebra, isn't it? Yeah, perfect. So this is actually an idiopathic cervical deformity. This has just happened. It's not a fracture. It's not a tumor. It's not secondary to anything. This is just someone who is unlucky enough to have gone through this process to now become significantly unstable in the neck and subsequently myelopathic. So you can see how your triangle, again, you've got deformity, which then now it's been left to this point has caused cord compromise and neck pain. They've had a corpectomy from the front. This is 2-level corpectomy, really big surgery, obviously, which again isn't enough on its own. So this person then has to have another second thing to restore the stability. Once you start messing with the neck stability, you know, it's significant work. So this person has 360. Yeah, pretty terrible. This is idiopathic. No idea why. What's this? I'll be amazed if anyone knows this, but just shout something out. Any thoughts?
You had a previous surgery.
Yes. Perfect. Very observant. Nice. How can you tell?
On 5/6 on the MRI.
Yeah.
Yeah, there is like an artifact or something like this is not
definitely
really clear.
Definitely, yeah. So actually, yeah, you're right. So this is a really sad case. You can see just about, if you squint enough, this person has had a 2-level ACDF very recently. Can you see these 2 tiny little blobs there?
Yeah.
That's part of a radiolucent cage. So someone's had a 2-level ACDF. The surgeon, we won't name names, has somewhere else has tried to put 2 cages in, anterior cages, to do an ACDF for neck and arm pain. But the first cage has gone in. There's only 1 cage in there. The second one, after taking the entire disc out, couldn't get a cage in. And so therefore this guy has basically been left to wander around with nothing in his neck, so an unstable neck because there's no disc there because it's been taken out by someone, and he's fallen into kyphosis, right? Because there's nothing there to hold the stability of the neck. So this person has got a significant cord compression myelopathy and now an unstable neck, and that's been left to now come into this point that when he stands up, his neck is kind of forward like this. So has to have, again, a corpectomy to take the entire thing out. You can't fit a cage in there. And then to fuse from the back, really, really big surgery. So this is an iatrogenic deformity. This is the kind of thing that, you know, of course, it's very unlikely. But when you start to do surgery for people for neck and arm pain, this is the kind of thing that could happen. You know, it's no laughing matter. So a significant thing. A tip, a box full of golden nuggets for any surgeons out there would be: don't let someone just walk around with no cage in their neck and not emergency blue light them to a hospital, which unfortunately didn't happen for this guy. So that's pretty poor.
What was the thing in the front of the spinal?
Which thing?
So in the around the spine, the vertebral body, there is something.
This?
No. In the post-surgical X-ray.
Oh, this stuff?
No, yeah.
Oh, this.
Yeah. The thing is that lies in the vertebral body, actually.
Yeah, so it's just the way that the orientation is. This is an AP view, so this is a cross link that's at the back. You can see it there. So they've got the corpectomy cage at the front, and then they've had to go PCDF from the back. But to give extra stability, that's a cross link there. So it's just the way that, because you're seeing it from AP.
Oh, okay. Thank you.
From anterior to posterior. Yeah, but good point. What's this? This person comes in with acute neck pain, and their chin is now suddenly on their chest. Any thoughts? So let's say someone comes in to see you in your FCP clinic or whatever. They come in and they've suddenly got neck pain and their chin is on their chest. I guess obviously you probably say this is a bit odd. What would your first question be? And looking at that picture, what's your question?
Whiplash accident?
Maybe. Anyone else? So it's hard to see on this, but if you look at X-ray, obviously we're looking a lateral here, so we want to see a nice big vertebral body block with a disc between it. At this point here, you lose the blocks and suddenly it's gone. So this is a person's MRI scan. Sadly, they have metastatic disease, which has completely taken the vertebral body away. So when you looked at this on a T1, unfortunately I've not got a T1 image. This on a T1 MRI scan would be black. Effectively, all of the vertebral body has been destroyed, and so it's there's no space there. There's nothing to it. It's just, that's why she's fallen forward, because this thing is no longer accepting load. This is CT scan. There is no vertebra there anymore. So if someone ever comes into you with a chin on their chest suddenly within the last few days, probably quite worrying. This is a true, acute deformity, which normally is secondary to nasty cause. Okay, last couple of cases then, and then we can go into questions if people want. So what's this? This nicely shows the fact that it's in a particular part of the tracts. What do people think this is, looking at it? Bit of an odd one. So go back to thinking about what did that. So the rest of the MRI looks pretty normal, apart from there's something in the spinal cord. The cord signal looks different. Think back to that first image we looked at when you're trying to establish where the anatomy is. What's weird on this?
The C1, C2 doesn't look quite right either, as well as the cord signal, right? So
Sure.
potentially some old unstable injury or fracture that's left established cord signal change.
Nice, yeah, perfect. So something looks weird at C1 too. There's not, you can't really kind of make out the C1 arch. The peg is kind of all disaggregated here, isn't it? So yeah, this is an old non-union C1-2 instability. interestingly, no, in the history for this person, no real trauma. Someone who's seen in pain services, has neck and unilateral arm pain for a long time. Nothing else interesting. Nothing on examination at all, really, that interesting. Nothing neurological. But when you look at that, then again at the X-rays here of something dynamic, we've got a peg which is moving and bashing, basically dinking the cord repeatedly. So that's fairly odd, isn't it? Wobbly peg, but a non-traumatic one. No rheumatoid arthritis, no other factors particularly. But again, just something to consider. With that in mind, then, what's this? To give you a clue, obviously the person first came and had an MRI scan of their brain, and they got a little bit of upper spine at the top of it, or at the bottom of the brain scan, which then necessitated them coming to us. So what's this then?
I can't quite remember the name. Is it like Charlie malformation?
Chiari, yeah. So that's a good
That's
point.
it.
Yeah. No, you're right. So this isn't a Chiari malformation, but a good point. Chiari would look a little bit more. I've not got it on this slideshow, unfortunately, just there's not enough time. But Chiari would look a little bit more like the brain stem dropping down through this main hole here. So it would be this bit here would be in the spinal canal. This is obviously the signal change within the cord again. Does it look similar to the last one? Does C12 look normal? No, it ain't. So on flexion extension, again, this is a dynamically unstable peg, which again has to be fixed from the back. So this is, again, an unstable injury causing cord injury, myelopathic, young middle-aged person. Again, no particular reason as to why. So that's 2 in the last couple of years we've had. Last couple of cases then now. So this is someone in 2013. We'll go through these, then we can get to our questions. So this is someone in 2013 who then had a 2-level ACDF. There are the cages again. That's what they look like, radiolucent cages when you x-ray them. So they've had a 2-level ACDF at 3, 4, 4, 5 for myelopathy. And then later on down the line, then they come to see us. And effectively, again, they've got adjacent segment changes above and below. And at C12 again now, there's some significant changes here at the top. So these ones are far more concerning to think about, well, what are you going to do about them surgically? We ended up operating on this person because they're progressively myelopathic, and the cord compression at the top, the risk obviously with this person is that they've got no space for the CSF to flow through. So if it gets bad enough, it's a brainstem injury, they fall, they either paraplegic, or the CSF backs up and the cord, again, low brain stroke. So again, it's a significant thing to do, but here it's taking the pressure off the cord from the back, removing the C1 arch, but then you're going to make this thing incredibly unstable, and so therefore you have to put an occipital plate on. You have to fuse their head to their neck, so this person will never move their head again. So again, this is quite significant stuff to consider doing, and a problem at the CT junction. Last 2 cases for you now. Again, I'd be amazed if anyone can understand what this is. What is this? So the main canal kind of looks pretty normal. There's some little changes, but what's this massive thing going on here? Anyone got any thoughts? This is the negative of having it on Zoom. Otherwise, I'd point to people and get you to shout out. But this, so it's something coming from the front, pressing the cord backwards very significantly, with significant signal change, and you can't really see a whole lot of cord there at all. So this is very, very severe, again, stenosis from something. This guy came to see us as an incidental finding. He had no symptoms. He had no neck pain, no neurology, no upper motor neuron signs, nothing. Very mild dexterity changes, but this guy was, elderly with no other comorbidities. So this is just a slide to say, and again, to show you guys that this is structure, this is pictures, but people aren't necessarily their pictures. Definitely this person needs to see someone to have a discussion about things because it's so severe, but people are incredible in their way to adapt and tolerate certain stresses on the structures. So, you know, this is unreal, really bad cord compression and an asymptomatic person. We all thought that this might be some bony spur or something weird, but actually when you CT scan him, there's no bone there. So what this in fact is it's what's called a pannus, which is basically where the C12 is slightly unstable and it moves a little bit more than it should for whatever reason, normally in rheumatoid arthritis people. And because of that movement, there starts to become a swelling, a soft swelling that comes out of the joint, which then starts to compress the cord. The way you deal with that effectively is that you fuse the C12 because then you don't get any wobble around and you don't get any effusion afterwards. So it's like, a way to decompress, but then also to stabilize, to stop any more of this soft fluid and effusion. And then the last one then, so what on earth is this? What does this look like? Has anyone got any ideas what they think it could be? I mean, it's a pretty horrendous MRI scan. I couldn't believe it when I saw this, gent. So anyone hazard a guess?
Is it something inflammatory?
No, it's not, but good.
Okay.
Good.
It's just the dark, he's got dark discs throughout.
Yeah, it does, doesn't he? But the question is it just disc?
No, there's got some signal change here.
Yeah, sure. So in this area, the signal change. What about kind of near the discs? Is there anything else? Does it look kind of like a normal MRI scan from a perspective of, you know, the vertebral bodies or around that sort of area? Is there any clues?
The longitudinal posterior ligament.
Yeah, exactly. Perfect. So what it isn't is it's not multiple discs pressing on the cord from the back, although there are disc changes. It's the fact that everything is one continuous line. So again, it makes you think of the posterior longitudinal ligament, which is why it's important to understand your anatomy and what it should look like. So this is very, very, very severe cord compression. I mean, you look at that, that's now not a cord, it's just a slight strip of cord left. And that is a fused, a ossification of the posterior longitudinal ligament. So this guy has got a genetic predisposition to fuse his posterior longitudinal ligament, and it's thickened up, it's fused, and the cord is now significantly pinched. Again, this guy, not massively symptomatic, all things considered, but as a middle-aged person, what do you do now? Because if you were going to do something surgically for him, you'd probably have to decompress all the way from the CT junction, craniocervical junction, all the way down past the cervicothoracic junction, fuse his head to his neck, and this would be an unreal big surgery. So I mean, what do you do in this kind of situation? Very difficult. But again, it's important that now when you look at an MRI scan, I mean, you may well never see anything that looks like this, but when you're looking at your scans, if it's not just at the level of the disc, and if something is there behind the vertebral body, think about the posterior longitudinal ligament as a potential cause. Mad OPLL. Right. Well, thanks for listening to me talk, everyone. You know, hopefully it's been useful. It's hard to peg it at the right level for these kind of things, of course, with so many of you. But if you are interested in doing anything more, I'd be more than happy. So tell the MACP if you're interested, and we could do something face to face, a bit longer and a bit more in depth, a bit slower. But thanks for having me. Any questions? Please shout them out or put them in the chat.
Thank you very much, Matt. Tracing back the questions, I can see Abdul Rahman asked, what is the decision if there are symptoms but no cord changes?
Sure. So it's a good question. Depends on the patient and depends on the surgeon. So this is when shared decision making comes into play. Most people, the vast majority, there are no guidelines that support operating on people that are asymptomatic cord compression and signal change, because you can't make them better than normal. If you operate on them and they have a cord injury, well, then you're screwed. You know, that's a terrible thing to have done for someone. Effectively, with those kind of people, we watch and wait. Oh, sorry, did you say what if there are no signal changes but there are symptoms? I think we already answered that before, in the sense that if the cord is compressed, no matter if the signal changes or not, and if they are symptomatic, then we'd offer them surgery potentially if they wanted it.
All right. And then Aid asks later on, when would you perform a laminectomy? I mean, what are the criteria?
Sure, yeah. So laminectomy, obviously, you saw a few slides on there which were PCDF, right? A posterior cervical decompression and fusion, which effectively is a laminectomy with fusion. Back in the day, and certain people at certain times, they like laminectomy alone, basically just taking the back. I'll go back to a slide which would show it. So for this guy, for instance, if you then cut through from posterior to the spinous process and took out the ligamentum flavum and took out the spinous process and the lamina, obviously laminectomy here, you would decompress the cord and you would let the cord flow backwards. The problem with these ones is that if you do it at all extensively and you've got someone that's a straight neck or they're already kyphosed or there's already any kind of listhesis, etc., you basically make the spine unstable. So they're going to drop forward, and certainly a good percentage do drop forward into posterior post-laminectomy kyphosis. So they come forward like this. So in which case, a lot of posterior surgeries now for myelopathy are done with then a fusion, unless they're like 80 odd, they're old person, not able to really get through a big surgery, and you want to just take the pressure off the cord. And even so, they're going to get more neck pain. They're going to potentially fall forward and fail, but they're just not able to take on anything more.
All right. Just going a little bit further back about the laminectomy. Yeah, I don't see. Oh, as somebody says, to remind the Nuri paper you mentioned earlier. I don't know what it means, remind, but like, do you want to go through that again?
Oh, the Arya Nuri, yeah, sure. Yeah, so I'll get that up. I'm sure we'll be able to send the I'm sure we'll be able to send them out. But Arya Nuri, so basically, if you just put in Nuri cord canal mismatch, it'll come up. Just a quick cursory Google of cord canal mismatch will bring up what you're looking for. Like I say, it's only really been, they used to call it congenital stenosis, but I like the idea of a cord canal mismatch. It kind of makes sense more of what's happening. So it's this paper here, which is useful.
Excellent. What I would like to ask you, Matt, for the benefit of everyone, really. So, as a service, when you're looking at a patient, when you review them, what are the things that tip someone towards surgery, and what are the things that they don't? In a sense, okay, we have the symptoms on one side, and of course we have the structure on the other side. And obviously, when you look at them, when you look at things in your service, you probably look at structure, and you then try to correlate the symptoms. But what is there, like a very informative, simple bullet point thing that you look at and you think about when you review patients? You say, okay, 1, 2, 3 are satisfied, let's say, therefore surgery is an option. And then if you answer that as a secondary question, like we talked about prognostic factors sometimes, like but can you tell us a little bit more about what are really the prognostic factors that can help tip the balance between surgery and no surgery?
Sure. Okay, so two big questions. They probably again need much more time to go through them in full detail.
As briefly as you can.
Yeah, of course. So from a perspective of whether to do surgery or not, it's a two-step, well, it's kind of three-step process, I guess. Does this person have symptoms that are so I guess when you come back to your triangle, if it's pain, does this person have symptoms that are so bad that they're disrupting their life so much that they'd be willing for someone to cut their neck open with the risk of paralyzing them? You've got to be in pretty bad pain to consider doing that. So people have to have tried pretty much everything, right? They're at a point where the normal people that we operate on for cervical radicular pain and arm symptoms, they're just at their wits' ends. They've done everything, and life is just miserable, and so they're willing to take the risk. Although the risk is small, it's still there, and so the people inherently, when you start talking to someone about operating on their neck and coming from the front and doing this and that, it very quickly roots out people who will go, oh, it's not that bad. I don't think I'm at that point yet. So that's from a pain perspective. Their pain might be so bad, but the structure has to correlate, and you have to be sure that that's what's causing the symptoms. So that's when we use things like the nerve root blocks to really try and figure out how much improvement do you get. There's a lady you saw recently, I think, from you guys. But as just an overall point, someone's had a nerve root block. It's worked 90%. They feel amazing for a few days, a couple of weeks, but it doesn't last forever. That person is and they've got a surgical target that you can get in. It's big enough to get to. So they have to have symptoms that are bad enough. They have to have had everything else done. They have to have a target which is big enough to actually be able to go in and operate and do something to, some little tiny disc or something you can't really affect. The bigger stuff is easier to get to and sort. And obviously we have to know almost that is the cause of their symptoms. There's EMG evidence that they've got radiculopathy. They've tried this, they've done this, the nerve root blocks worked. It has to be fully worked out from a pain perspective, from a cord and from a neurology perspective. So if it's someone got a deformity or if it's just normal congenital or normal degenerative stenosis, DCM, again, the real question is, how bad are the symptoms? How bad is their neurology? And could they cope with it worse than they are now? That's a question we ask. Is it changing? Because people can have myelopathy that lasts for years. It doesn't really change. So how are you this Christmas versus last Christmas? How are you 5 years ago versus now? They can generally tend to see how they've got worse with symptoms. And so the question is, if we leave it another 2 years and you're worse again by a similar amount, or you could just fall off a cliff and get much, much worse, would you cope with that? Would you manage to live your life? And if someone's at a point where they say, well, no, I'd be too bad if I lost the use of my hands or my legs anymore, I'd be in a really bad shape. I wouldn't be able to work, or I wouldn't be able to live my life and do things because I'm retired or what have you, play with my grandkids, whatever. At that point, you then say, well, this is the time when we need to do something. Because as we say, with myelopathy and with decompressing the cord, you are aiming at very least to stop things from getting worse. If a cord is so bad that it's so deep, so compressed that the blood supply to the cord is so gone and the cord is so dead, there's gliosis of the cord. Even if you decompress them, probably about 5 to 10% of people will continue to get worse no matter what you do. The cord is dead. For most people, you're aiming to stop them where they're at, which is why the MGOA is useful. It's a tool for us that we say, if you're at a 15 or if you're at a 12, we can hopefully keep you at a 12 forever. There are some good evidence, and again, depending on what you read, that 50 to 60% of people after surgery for myelopathy, they get an improvement. But the improvement is not massive. It's maybe 1 to 2 points on an MGOA scale, which is, not huge, but it's not going to make them normal again. And we're not going to sell them the dream that you're going to be normal if you have surgery. But they might get an improvement. That's a cherry on top. The real prognostic factors, so far as we can figure out, if someone has signal change on MRI, they are less likely to improve. So the cord has already gone through a process where something's happened to it and its oxygen supply has been significantly cut off. So people with cord signal change are less likely to do well. There's another thing which we didn't look at today, but T1, if you look at a T1 image and the cord looks dark on T1, hypo-intense on T1 within the cord, that's really bad in the cord and they're not going to do well at all. So you want to get to them before the cord is dying stroke dead and has lost its oxygen supply. And generally people who are younger and got more physiological reserve. So, someone in their 30s is a much different discussion than someone in their 80s who's, it's just come to them. So those would be our points of view. There's lots and lots out there in the literature. So if anyone's interested, again, these are things to talk through in much more detail.
All right. Well, unless somebody has any other question, I think we're happy to wrap up.
Cool. Thanks very much, guys. Thanks for
inviting me. Thank you very much. Okay. Matt, if you can stay just for 5 minutes extra.
Oh, yeah. Yeah, no worries. Yeah, it's fine. Thanks, everyone.
I'm going to stop recording now.